Based on smoking and its impact on the cardiovascular system. Before joining Care Partners, I was working in Delhi in the Apollo, and there we used to see our patients, and the risk factors associated with coronary heart disease were different in a metropolitan city than that I observe here. Here the population is mostly comprised of farmers, daily laborers, and people who are of middle and low economic class. So they don't have any other risk factor except smoking, uh, which is a very contradicting factor, that without any other risk factors, these people are coming with acute ST elevation MI. 99% of the patients which I have seen and managed here, they have the only single risk factor, that is smoking. So we'll discuss elaborately about smoking, its pathogenetic mechanism of causing coronary disease, and the management, how to manage smoking and make the patient get rid of the habits. So in the last 10 to 15 years, there has been tsunami of premature coronary heart disease in young patients in India. In 2010, only 8.3% of the patients of less than 30 years of age had coronary heart disease, and in 2015 it has increased up to 10.5%. That is a massive 27% increase in coronary heart disease, and total death due to coronary heart disease has increased similarly to a massive 27%, and in all age group it has increased to 26%. So the data shows that we must be concerned about the young population. Among the risk factors which cause heart disease, they are classified into three groups: non-modifiable, modifiable, and novel factors. The non-modifiable risk factors include age, family history, ethnicity, gender, and previous history of coronary heart disease. Now, modifiable risk factors, they are habit forming like smoking, dyslipidemia, hypertension, diabetes, obesity, physical inactivity, and the novel risk factors, which are the recent ones. They are the biochemical, the serological markers of inflammation, or serological marker of ongoing atherosclerosis, which are C-reactive protein, fibrinogen, coronary artery calcium scoring, homocysteine, lipoprotein A, small dense LDL, and comorbid disease like renal disease, HIV. So coming to smoking, in India, people smoke tobacco in the form of cigarettes or BD or hookah pipes, and nowadays in Western countries and in United States, e-cigarettes have taken their place. So in rural population, mostly people smoke BDs, and in urban population, people prefer cigarettes. The cigarette smoke, we'll discuss about in detail about the smoke, its composition. Smoke is classically divided into two phases: the tar phase or particulate phase, and the gas phase. The tar phase or particulate phase, that phase which cannot be filtered by these glass filters, and this contains around 10 to the power 17 free radicals per gram of tar. Similarly, the gas phase, which can be filtered through the glass filter, it contains around 10 to the power 15 free radicals per puff of smoke. And the free radicals present in the tar phase, they are long-lived, they last for hours to days to months. And free radicals in the gas phase, they have short half-life, lasting for few seconds. And smoking is mainstream smoke or side stream smoke. Mainstream smoke, the smoke that is drawn through the tobacco into the active smoker's mouth, and side stream smoke is that is emitted from the burning end of the cigarette. Mainstream smoke can comprise 8% of the tar and 92% of the gaseous component, whereas the environmental tobacco smoke, which results from side stream smoke and small fraction of exhaled mainstream smoke, which mainly contains toxic gaseous components. So the smoke has been analyzed by this has been analyzed previously, and it contains around 400 chemicals, among which 60 substances can cause cancer. Among the other important substance is the nicotine. Nicotine is the substance because of which people are addicted to smoke tobacco. This nicotine, once it is in the gas, it enters into the lung, it quickly gets into the bloodstream, reaches the brain. Once it reaches the brain, it releases dopamine. Dopamine provides a pleasure and relief effects. Because of dopamine, patients are addicted to cigarette smoke. And each cigarette provides 1 milligram of nicotine. So, nicotine has been studied, but nicotine exposure alone report no change or very mild change in the vascular, which nicotine alone does not cause any change in the blood vessels reactivity, and only high dose nicotine in experimental models can cause atherogenic change. And current evidence suggests that at concentrations similar to the smoker's blood level, it has only minor effect in the initiation or propagation of atherothromboembolism. So nicotine itself it is not the culprit to cause atheroembolic processes going on inside the smoker's body. So nicotine can be considered as a nail, it only provides the pleasure effect. Among the other substances found in the smoke, one of the important compound is carbon monoxide, which was suspected to cause atherosclerosis or thrombosis, but recent data suggest it unlikely. Recent data suggests that it unlikely cause atherosclerosis. And similarly, other polycyclic aromatic hydrocarbons like benzene, formaldehyde, ammonia, they are found in the tar fraction of smoke, and they have been studied, and in experimental models only they accelerate atherosclerosis. So it is the other innumerable substances, toxic substances found in the smoke. Actually, they are the main culprits in the smoke which cause progression of atherosclerosis and embolism. So coming to the pathogenesis, how smoking can cause extensive damage to the system. So there are 5 mechanisms by which smoke can cause injury to the vessels. First is vasomotor dysfunction. It has been seen that when chronic smokers' blood is exposed to cultured endothelial cells, it causes decrease in synthesis of the nitric oxide. That means there are innumerable substances which affect the genesis of nitric oxide, and that inhibits nitric oxide synthase, which cause a decrease in synthesis of nitric oxide. And nitric oxide itself, it not only helps in the vasodilatation and maintenance of the vascular function, rather it also helps in expression and activity of other uh, functions like regulation of inflammation, leukocyte adhesion, platelet activation, and thrombosis. So nitric oxide is an important vasoregulatory molecule in the process in our body, which acts at the cellular and molecular level, maintaining circulation, inflammation, leukocyte adhesion. So once vascular dysfunction occurs because of prolonged smoking, the nitric oxide synthesis is inhibited, there is reduced synthesis of the nitric oxide, which leads to this um, endothelial dependent vasodilatation. So once decrease in nitric oxide synthesis occurs, this leads to increased expression of adhesion molecules over the endothelium and some subsequent endothelial dysfunction. This has been documented that in smokers, the soluble VCAM, ICAM, E-selectin, which are the adhesive molecules which are expressed in over the endothelium and over the inflammatory cells, there the levels are higher in smokers. So this leads to increased adhesiveness of the endothelium, and this increased adhesiveness leads to increased adherence of platelets and macrophages, which provoke inflammatory processes. So once vasomotor dysfunction occurs, this leads to starting of the inflammation. Actually, this free radical, the oxidative stress mechanism starts once the smoke enters into the bloodstream. The free radical, they induce this inflammatory process. Free radicals, they induce these inflammatory cells to get activated. They express enhanced number of adhesion molecules. They also multiply these radicals by different mechanisms like NADPase oxidase, xanthine oxidase, they are activated. So free radicals are produced in a rapid manner, which cause oxidative stress. This oxidative stress leads to activation of inflammatory cells, and this inflammatory cells then starts entering into the transendothelial space through transendothelial migration and activations. And it has been seen that multiple inflammatory markers like CRP, C-reactive protein, interleukin 6, TNF alpha, these levels are increased in both male and female smokers. So once these inflammatory cells are activated, they enter into the subendothelial space. They get activated, they oxidize the lipoproteins present there, and oxidative modification of the lipoproteins leads to, and then they engulf those lipoproteins, oxidized lipoproteins, and turn into differentiate into foam cells. And in this, it has been seen that that is those in smokers, the lipid peroxidation and autoantibody titers to oxidize LDL are very high, has been found, and this shows that this is not only theoretical, it is actually going on inside the body of the smokers. There is oxidation of lipoprotein, oxidation of LDL particles. There is increased uptake of the oxidized lipids into the macrophages. They are differentiated into foam cells, and ultimately there is remodeling, and atherosclerotic plaques they develop. So smoking causes this much of injury that it leads to oxidative stress. Oxidative stress leads to decreased oxide, which cause activation of inflammatory cells. Activation of inflammatory cells again, it provoke oxidative stress by their um, by the enzymes present in them, and this lead to lipid peroxidation and oxidized formation of oxidized lipoproteins, and these are again taken up by the macrophages, and this lead to propagation of atherosclerosis. So again, about the coagulation abnormality or thrombotic property in thrombotic environment in a smoker's body. In a smoker's body, there is prothrombotic and altered fibrinolytic state is present. Because of continuous exposure to the smoke, there is platelet dysfunction, which lead to hyperaggregability. This hyperaggregability is also because of decreased nitric oxide. Second, smokers have higher fibrinogen level. They have decreased tissue factor pathway inhibitor 1 and decreased level of tissue factor, which is a state of hypercoagulable state. They also have high RBC count, hematocrit, higher blood viscosity, and inflammation. These actually add to the prothrombotic state already present. Similarly, there is altered fibrinolytic state. It has been seen that in smoker's serum there has been significantly decreased substance P stimulated tissue plasminogen activator release, and there is altered ratio of DPA to PAI1 plasminogen activator inhibitor 1 ratio. So this dysfunctional thrombostatic mechanism, it promotes initiation and propagation of thrombus formation and limits its dissolution, which is a cornerstone for the prothrombotic state present in the smoker's body. So in patients coming to us in acute myocardial infarction without any risk factor, smoking can cause this much of damage. Smoking causes prothrombotic state, decreased fibrinolytic state, which enhance the formation of clot. Even patients who have thin cap atherosclerotic lesions in the coronaries, they have a very high risk to have an acute MI. So there are these are the theories, but there are several evidences for atherosclerosis in smokers who have no symptoms. Thoracic aortic atherosclerosis has been seen by the transesophageal echo, which is increased in cigarette smokers. Both active and passive cigarette smoking is associated with increased intima media thickness in the carotids, which can be assessed by carotid ultrasound. Cigarette smoking is associated with increased MI, and an immediate reduction in smoking is associated with decreased MI event, myocardial infarction acute events, and there is a old study where autopsy of 1433 men and women aged between 15 to 34 years who smoked